This conference will now be recorded.
Hey, Kevin, are you there?
Oh, there we go. How's that working? Yeah. Little technical difficulties. I'm still new with this GoToMeeting stuff. So this kindergarten level diagram, I actually had something that I used to put in my EMT classes. Kind of funny, I would hand it to them and said label it, but it was very basic. But it does show the actual alignment of the heart. If you look at this this slide, it actually shows that the heart is slightly tilted towards the left-hand side, with the bottom being facing towards the midway between the waist and the armpit. All right, I bet you I won't be able to check slides again. This is interesting. So this extra, that kick from the chief sinoatrial node says we're beating at 60 to 100 beats per minute. It's sending a message down the line. So it's telling the AV node, which is right at the bottom of the right atria, it's going into the septum. It's telling them that's the deputy chief. Okay, the AV node, atrioventricular node, which is again is taking orders from Chief Zoddy, sending it to his first deputy, the AV node. Hey, tell everybody below you, and go from company officer down to the lowest probie. We're beating between 60 and 100 per minute. Absolutely, I am not changing my mind. we're doing it. So SA is the driving force. Well, it just so happens that if we're damaging our heart, there's a back. As there's a deputy chief, as we know, the deputy chief being the AV node, if Chief Zoddy is not there telling them to beat at 60 to 100 beats per minute, he knows he has to take over. When it goes below 60, he's not receiving his orders from Chief Zoddy. He has standing orders from Chief Zoddy that if I go below 60 per minute and you don't receive further orders from me, Mr. AV node deputy fire chief, you are going to beat between 40 and 60 per minute. Standing order. So Mr. AV junction, AV node, is going to go, okay, boys, down below him. I have no other order, so I am going to tell you our standing orders to be between 40 and 60 beats per minute. Okay, so he's passing along the line. Down the line, from the AV node, it travels down that septum between the atria and the ventricle, and it's going down the line, and they're all passing the signal down to all beat between 40 and 60 per minute. If Chief Zoddy is still sending the signal down, so the AV is just sending that signal along, saying beat to 60 to 100. But if not receiving the orders, AV is going to tell them 40 to 60. Down these Purkinje fibers, they call them. Those are the messenger boys. Goes out around the heart, and they all beat nice and synchronized and make a nice pulse. And it shows up on EKG rhythm and looks beautiful. However, it just so happens that things like 9/11 happen. In the body, 9/11 happens too. We call it a big heart attack. So in order to keep the heart going, all of these levels have their own idea of what they want to really beat if nobody's telling them what to do. So the Purkinje fibers and the ventricular fibers that fire the ventricles also know what to do in case that the deputy chief is not passing the message along. So these Purkinje fibers and the ventricles know that they're going to beat between 20 and 40. Without further orders, I'm going to beat between 20 and 40. But if I do receive orders, I can beat at 60 per minute, not a problem. You got to tell me to do it. So SA node in a normal heart, the signal's starting at the SA node, going through the atria to the AV junction, and sending that signal all the way down the Purkinje fibers around the heart and back up. So it just gives a nice, smooth, fluttering beat. But they're all independent thinkers if they're not allowed to, if they don't receive orders. Kind of like a junior probie. You know, if you don't give them orders when they're in their first year, you know, they're going to be off doing whatever they want to do. That's kind of the ventricles with their own intrinsic rate. They're excited. They love to do this. But for the most part, the impulse will start at that SA node, travels through the atria, goes down to the AV junction. AV junction says, okay, scratches his head. I got some orders, so I'm going to send it along again. Goes down the Purkinje fibers, down the ventricles on both sides, and up. It makes a nice. All that happens between 60 and 100 beats per minute. A flash, a flash, a flash, a flash. Knowing about this automaticity means that everybody else is going to do what they want to do. They're not told to do otherwise. It muted me, and I can't do this. I can't do two things at once, I guess. Nope. I'll have to fix this problem another time. There it goes. So remembering the impulse there is held for a fraction of a second. Just we've got everything is a little bit of a delay. So when that SA node is generating that quick impulse, it shoots it down the ventricle. The AV junction catches it. Goes, okay, got to relay. It was my messenger. It does a quick pause. Now, what that does is it allows the blood, when it's ejected from the atria, to go down into the ventricle. So that little pause between the SA node and the AV junction receiving and going like this to pass the signal along allows the ventricle to fill. So the contraction that we have of the heart, which is one big flow, is called systole. That systole is a squeeze. The opposite term of systole, which is relaxation. So now we've squeezed and we're pausing. That's called diastole. So you've heard of systolic blood pressure and diastolic blood pressure. It's the same thing. Systole is the squeeze, the systolic, and diastole is the relaxation. So our squeezing pressure is our top number. That's when the heart's beating. And our bottom number is when the heart's relaxed. It's two different numbers we hear when we take a blood pressure. This is the route that the electrical signal takes. Starting at the SA node up in the upper left corner of the base of the top of the SA node in the right atria. It travels downward to the bottom of the right atria, the atrioventricular node, travels through, down, and around. It all happens within a fraction of a moment. So when the blood flows, the deoxygenated blood enters right atria from the inferior and superior vena cava, passes through the tricuspid valve into the right ventricle, is squeezed through the pulmonic valve and into the pulmonary artery to the lungs. Gas exchange takes place and becomes oxygenated from the lungs into the pulmonary artery into the left atrium. Very quick, within the span of one beat, all that happens. Now, does it mean that one cell goes and travels that distance in that one beat? Absolutely not. Remember we talked about it takes all the cells, a full 20 seconds to go through the body. So, or to reach the cells, I should say. It's a very much a slow process. So as this happens, we're creating our nice blood pressure. From that left atrium, it goes through the bicuspid valve into the left ventricle, where it's the main part of the pump, and it goes through the aortic valve and into the aorta to pump to the rest of the body. Coronary arteries, which coronary means heart, and these arteries are designed specifically to feed the heart. The heart is just like any other muscle in the body and any other cell. It needs oxygen and it needs glucose. So the two objects that it gets when it opens, it gets oxygen and glucose. So the oxygenated blood is going to travel through the aorta to all the arteries of the body during systole. At diastole, right at the arch of right at the base of the aorta, when the heart does not beat, when it is actually in diastole, the valves that open up the coronary arteries now allow for blood flow into the coronary arteries. It's not done during an actual beat, it's done during relaxation. As arteries travel away from the heart and they branch downward, they go down into arterioles, down into capillaries, and then into venules, into veins, and then back to the heart. The capillaries are the smallest vessels in the body. These arterioles and capillaries, get really, really small until the capillary beds are only one cell thick. So they basically, the red blood cells have to line up back to back in marching order, just like a nice military column right through. And this allows for oxygen to diffuse back and forth from the cells into the red blood cells. They don't actually come in contact. It's just the oxygen that gets transferred over, and carbon dioxide gets transferred back. And a nice little, very basic diagram, I would say, of the whole vascular system. It just shows how it's broken down. Questions so far? That's kind of hard to follow when we're sitting here talking about it versus using a lot of diagrams and pointing and shooting and things like that. But for the most part, it's a closed system, like our fire pumps, and our hoses and everything like that. If you take out one portion of the system, the whole system does back itself up, but it will fail. If you take away the fluid from the vessel, we're not going to do any good. Which is why when the theories change with trauma about pumping more fluid into them versus actual oxygen carrying capabilities.
So your first 4 electrodes that you put on pretty much covers all that.
Your first 4 electrodes can give you an electrical scan point of exactly what we've just covered. So we're not going to really get into that, because that we could spend hours upon hours. But I'll talk about a basic understanding of 12 leads. Very, very, very basic. It won't be diagnostic or anything like that, because I don't actually have slides on 12 leads. But if you picture in your mind how a 12 lead, we all learned in the basic class how to place those electrodes on the chest. And if you look at how they are patterned around the left side of the chest, that is your camera. Each one of those ventricular leads, or precordial leads, are a camera in themselves. So they are looking and they're shooting in different directions. Primarily, the views you get are shooting from that towards the heart. So it's going to give you a view towards usually either the left shoulder, the right shoulder, or the left leg. And those will give you a camera eye, bird's eye view of what's going on in the heart electrically. So in electrical systems, if you provide an extra ground, it's called the path of least resistance. The thicker the wire, the smaller of the fire hose, the more resistance is there. So it's going to delay the transmission of an electrical signal, just like with your own, home current. If you delay the electrical signal, it looks differently. What you see with an EKG is what they call an oscilloscope. An oscilloscope, electronics technicians used to use for years how to diagnose sine waves and things like that, the electrical system. And all an EKG is really just a glorified fancy oscilloscope. And when a perfect heart transmits a picture of an EKG that looks beautiful. Most people, there are some slight variances between different people physiologically, which are kind of sometimes hard to distinguish. But for the most part, we all look alike. Normal looks pretty similar. And so what happens is when we have low oxygen levels in our heart muscle from hypoxia or from ischemia, it changes the look and the view of the electrical signal passing through the muscle. I talked about just earlier in this class how they're passing the signal along as it comes from the SA node. So when that passes through a deoxygenated muscle or an ischemic muscle or a damaged muscle, that signal that's coming along, that electrical signal that they're passing along, is going to go, whoa, I can't go around that easily. I can't pass through. So the change in the view of the oscilloscope is what we're looking at on the electrical part. It really doesn't represent how the heart's beating, the physical, the mechanical action. So which is why sometimes when we have a cardiac arrest, we have a perfectly looking electrocardiogram and the heart's not beating, because that's only the electrical picture that it's painting. It doesn't represent the actual mechanical function. Does that make sense? Okay. If it was an EKG class, we'd have all kinds of nice little things. We could pick things apart. I do it all the time. Actually, 27 years as a medic, I still take EKG classes to find vagaries and things. I love it. It's a lot of fun. Some of the different acute coronary syndromes we've experienced, we've talked about, it's been coming around for years. First one is angina pectoris, also AKA angina. Angina pectoris literally means chest pain. Pectoral angina pain. Usually brought on by exertion. Although I did have a case last night, though, the 47-year-old guy absolutely sitting at rest, just, kind of there. Went away on its own, came back on its own. He went to the hospital, got 1 nitro, relieved it. He had negative enzymes, negative EKGs, all these things. And they're like, yeah, well, geez, there's no marker that he had any damage. Well, let's go send him for a stress test and see if we can reactivate that and figure it out. Because usually, again, it's brought on by exertion. With him, it was just at rest. So angina indicates a portion of the heart is ischemic. So it's not damaged yet. We don't have any real permanent damage. It's that syndrome of ischemia, the lowering of oxygen to the heart, causes some aggravation in the heart muscle. It doesn't like it. A lot of the times with an electrocardiogram, this will show up as ST depression and lowering of the segment of the EKG following each complex. And that's simply irritated heart saying, I don't like not having my oxygen. Give me my oxygen. So it's aggravated. So it goes, I'm going to shoot you a little bit of pain. Here's a little bit of pain. Here's a little bit of pain. We know that happens, when we get pain, we kind of respond to it, right? So in this case, if angina is brought on by exertion, we got chest pain on exertion. What are we going to do? Stop the exertion. So we sit down. It lasts between 2 and 15 minutes because usually we've kicked, the chest pain has kicked us in the chest and went, stop doing that. So they sit down, it goes away, they feel better. Or if they know they have angina, they pop some Pez, some Nitro, and it goes away. These also are good mimickers of MIs. Some people have called these in the past the pre-MI. Hey, you're having an ischemic syndrome. It's something that's telling you there's a vessel that's kind of either spasming or becoming blocked. May not necessarily be currently blocked, but it's getting that way. And so it can mimic and have the same symptoms as an MI, which is radiation to the neck, the arms, the jaw, the back, the shoulders. Rule of thumb, any pain above the level of the belly button, think about the heart. So it could be anywhere. They have cool, clammy skin, diaphoresis, dyspnea, or shortness of breath, anxiety, nausea, vomiting. Any one of these, any combination of these can all present. Women, elderly, and diabetics may show atypical signs, which is now where they came up with this acute coronary syndrome, because they don't always. Women are as complex in medicine as they are in life to us guys. And women paramedics recognize acute coronary syndrome on other women better than guys do. They do. So understanding that they experience life different than we do, we're moving forward, but we have to understand that. So ACS is a way for us to understand that anything that occurs, pain or any unusual symptoms, have to be lumped into this ACS category. V-Fib, our favorite cardiac arrest rhythm. So that normal, nice, heavy squeeze that we get at each beat, which results in a nice squeeze of the heart, not happening. It basically it's chaotic. The atria are firing asymmetrically with the ventricles. They may be firing at the same time. It's just chaos everywhere. Chaos reigns. So on the oscilloscope, which is right below this heart right here, that is the oscilloscope known as the EKG. That's an improper EKG. As you can tell, it's like all over the place. It's gobbledygook. There's nothing organized. There's kind of chaos. That's what VF is. The ventricles are not squeezing. There's no pulse. There's no blood flow. This is, of course, early defibrillation is the key. Now, I know they say, the first thing we do with cardiac arrest is we get on the chest, right? We start thumping and pumping. And so that is a bridge to defibrillation with V-Fib. Because the only thing that's going to stop this is a measured pulse. So a defibrillation, while it's not, it can't lock onto everything and generate energy. What it's going to try to do is going to reset. Got to push that reset button. We all are in the internet age, the wireless internet age. So how many of us have been on the phone with our internet provider and saying, we're not connecting, we got no internet here, but we got a perfect wireless connection. What's going on here? They say, well, I want you to go over and unplug your router and wait 5 minutes or 3 minutes, whatever the term is, and then plug it back in and see what happens. That's defibrillation. We're going to go in, we're going to apply some energy to hit those electrical impulses in the heart that are firing chaotically everywhere and tell them to go, stop. I'm pointing at you. I don't want you to fire. I want you to take a minute, collect yourself, and then resume. And that tells the SA node to go, hey, Chief Zoddy, it's time for you to take over. That's where the deputy has already created 3/4 of a parking lot. And now the boss is going to come back in and go, we're not doing good here. It's not necessarily that the deputy's done wrong. It's that he's not seeing the whole picture and he's telling everybody to go everywhere, you know, and he's over his head. So the boss man, the SA node, has been told, kick in. The rest of you guys better listen to the boss because he's in charge. Oh, all right, Mr. Defibrillation, I'm going to listen to you for a moment. And then SA node pipes up and goes, all right, fellas, let's regroup. Let's attack this from both sides and let's reorganize and accept my signal, the beat in once, and a 1, and a 2, and a 3. Go. Start beating it. That's our hope. So we're not actually doing much. We're not jump starting the heart. You know, the theory of the jump start is we're applying energy to get something to start. We're applying energy to stop the heart. Stop what you're doing. Think for a second. Breathe. Divers who are here, when you're in trouble diving, the 3 rules of when you're in trouble diving: stop, think, breathe. So this is our coronary version of stop, think, breathe. This is, wait a minute, what's going on? Whoa, okay, thank you, Chief. Thanks for the signal. Now we know what to do. Now we're going to kind of be an a 1, and a 2, and a 3. We'll go. So hopefully it gets a little more organized. So ventricular tachycardia. This is the next rhythm that, again, is not a healthy rhythm, but it's going in the right direction potentially. This may or may not have a pulse. So remember I said earlier that, you know, the rhythm that's there, it does not necessarily represent what's happening mechanically to the pump. So VTAC is one of those rhythms there that can actually show up. It's nice and regular. It looks up and down, right? It's kind of starting to look organized, but not quite. So that inherent ventricular rate, remember they like to beat at 20 to 40. They're just going, I'm going crazy, you know, and going, yeah, we're beating crazily, but we're organized. We're all doing it together at least. You know, so we're a great company. We're a baseball team. We're batting on the same planet. We're together. We're just kind of going crazy. We've had too much caffeine. We're going out of hell. The problem with this, as the rate gets higher, it's no longer going to push blood because it's not allowing blood to get back to the heart. Everything's kind of going so fast that it can't do much. You can have a pulse with this. Usually what happens is they end up with a pulse with this because they've never lost their pulse to begin with. So a person can get into a ventricular tachycardia before the cardiac arrest. So this eventually will turn into Mr. V-Fib. It's allowed to happen because what happens with this is that cardiac output pretty much goes down to nothing. So they're not pumping out. There's really no systolic blood pressure. Diastolic blood pressure is really not there. We're just kind of going so fast we don't have enough time to fill the heart. It's just dun, 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 dun. You know, so the ventricular rate is anywhere between 200 and 320 per minute. That's fast. That's fast. So our solution to this is either medication, if they do have a pulse and they're kind of stable, but for the most part, this is another electrical shock. Okay, and this is another electrical shock, but it's a specialized electrical shock. If they have a pulse, this is going to be a synchronized electrical shock. It means it's going to try to hit in between those waves up and down. So it takes the cardiac monitor and its computer brain to hit at the right moment. So the defibrillator will actually pause for a second before it delivers the electricity. So it hits between those runs. Most of the time when you see this, they actually do have a pulse. They're unstable, so we have to use electricity. Ventricular tachycardia. And what all the V-Fibs do, and the cardio version, hopefully the cardio version doesn't do it for very long, is create this one. Asystole. Asystole. Remember, systole is the beat. Asystole is the no beat. This is cardiac standstill. Absence of electrical electrical activity in the heart completely. Flatline. So AEDs won't allow defibrillation on this. They won't do it. They will on the previous one, even if they have a pulse. So you can put an AED. Saugus Fire Department, back in the day, we just had AEDs, put the AED on a chest pain patient, which was the police chief. I'm not sure if there was animosity there or not. But they put it on. They successfully converted the police chief. Police chief was very appreciative. Medical director was not, because it was, you don't put an AED on someone who's talking to you, because it is, again, a computer brain. It can't decide if a person has a pulse or not. So asystole, very low chance of recovery. If we have an asystolic arrest, pretty much you're already behind the 8 ball. The person's not likely to survive. Pretty much perform CPR until more advanced providers arrive, but that's going to be 15 minutes. The current standards. So, which leads into the next one we talked about earlier, is what they call pulseless electrical activity. Now, any rhythm that's generated on the EKG that doesn't have a pulse, no matter what it looks like, is technically a pulseless electrical activity. Even V-Fib is a pulseless electrical activity. However, we call it V-Fib because it's an identifiable rhythm, and it's not, generally speaking, it's just assumed that it's a non-pulsatile rhythm, so we don't call it PEA. But we can have a completely normal looking EKG and they won't have a pulse. There are a lot of different reasons for that. Most of it is combination factors of medical, like things like acidosis and hypovolemia and hypoxia, and different states of trauma allow for the heart to keep beating, but absolutely no mechanical beats being generated. Huge MIs, the heart can still sit there and beat, just doesn't look very well. So no defibrillation happens with this. There's no circulation going on. We have to figure out why this person's in PEA. So they call it the H's and the T's. And we kind of go down a list in our brain when we're working on these and figure out what's going on. Or it's, again, we work them until they're gone. So cardiac compromise of any kind, no matter what the noticeable morphology of it is. We talk about the squeezing, dull pressure in the chest, feeling a heaviness in the chest, or sharp stabbing pain in the chest with radiation to the arm or jaw. That's kind of your classic chest pain. This is what we used to always debate. Any paramedics? Okay, so you've been paramedic long enough to remember pushing on people's chests? Okay, so you are. So you remember ruling people out because they reproduced their chest pain? How accurate was that, with hindsight? Not at all. Yeah, exactly. So we used to, and this is before 12 leads, we used to push on, if we could push on their chest and reproduce that pain, that was a job. Whoa, boy, how wrong were we? We found out that it's all anything, any pain. Like I said earlier, any pain above the belly button treated as a cardiac event until you can prove otherwise. And the only way for us to prove otherwise is for them to have a troponin, in the hospital, and we don't do that in the field. So if it's above the level of the belly button, we assume it's cardiac. But this first one, squeezing, dull pressure, feeling heaviness on the chest, sharp stabbing pain in the chest, radiating the arm and jaw, is the classic. As it was presented, this is your MI kind of pain. So we do the nitro ×3 fast ride to the hospital with aspirin, oxygen, yada, yada, yada. Not really classic acute coronary syndrome kind of stuff. Again, we're painting the big paintbrush with ACS. So suddenly below it, as you can see on the list we've got here, things like pale skin, difficulty breathing or dyspnea, anxiety, irritability, feeling of impending doom, abnormal pulse or BP, epigastric pain, nausea or vomiting. All of these on the list, kind of give us a broader spectrum of symptoms rather than your classic chest pain. So we think about ACS in the long-term wise of maybe we should really be doing 12 leads on all of these people. So now our mentality is we do 12 leads on everybody, if they have anything, especially the ladies. And because diabetics and ladies experience these symptoms differently, guys are usually the ones with the classic, top of the list stabbing chest pain. The ladies are the ones with the profuse sweating, diaphoresis, syncope, the Hail Mary syncope in the church, things like that, where they're having their MI. So thinking outside the box. Aren't you? Yeah. I was thinking about that yesterday. Okay, so ETB working for basic service. You and your partner enjoying a relaxing afternoon or a warm fall day. The radio screams the lights. Squad 51, you're needed to respond to 321 contact drive for 58-year-old male with chest pain and shortness of breath. You scramble the rig and tear down the road with lights and sirens blaring. As you arrive at the address, a woman rushes out to meet your ambulance. Please, you have to help him. Come on, hurry. I think he's having another heart attack. Another heart attack. Okay, so ding, 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 ding. Something's going off in our head. Now what? What do we do?
Conscious, alert.
Oh, he's there. He's chest pain.
Does it feel like the last time this happened?
Good question.
When was the last time?
Last week. No. 4 months ago. I had 5 stents placed.
You on any medication?
Metoprolol, Vasotec, Nitro. Yeah, I popped 4 of them.
No.
Right, sure. Nothing wrong. Okay, so your BLS crew considerations are, so BLS in New Hampshire, we're able to capture 12 leads, okay, and transmit them. We can't look at them, but we can transmit them. The magical thing is they automatically print out generally, depending on how you have your device set up. If you're not capable of doing 12 leads, I do recommend you do. It just helps, at least saves a step. You want to get ALS rolling. I mean, I know here we have Huggins right here, but I mean, they don't have cath lab. So you got to think outside the box. Is this person going to have a heart? Is this person having a heart attack and going to Huggins going to be their best decision? You think?
Sure.
Okay.
However, you get thrombolytics, you get the heparin, you get cardiac consult way faster than what you get China.
Where do you go from here?
If we're in all, we'll go to either
Concord or Portsmouth.
if you go down 16.
With bypass protocols, yeah. I know, yeah, definitely. We're actually, Romano was telling me that it's going to expand a little bit more, I guess, but not yet as far as bypass goes. So delay, again, time is heart muscle, depending on how your system is set up. You may only have a BLS ambulance, so that's the closest available facility, which is Huggins. And if Huggins is running strepto, or well, it's probably TPA now, definitely a good shot to go there if you're basic level. Advanced level, still the same. I didn't hear the aspirin though. Aspirin. You're thinking about it, okay. Virtual aspirin. Okay. How about what if they take an aspirin every day? They take one. Yeah, take one St. Joe's. Or actually, I'm dating myself. They don't have St. Joe's anymore. The one baby aspirin, a little bare low dose.
They'll get 3 more.
So give them 3 more.
Give them 3 more. Yeah, load and dose, 324. Good. All right, so our impression is going to be 58-year-old male, average build, sitting, clutching his chest, breathing labored, slightly fast, ABC, seems alert, answers your questions, pale and diaphoretic.
How about a blood sugar?
Okay,
We call that.
sure, well, doesn't matter to me, he's 250. How's that?
Okay.
Senior present illness came on, he was mowing his lawn, riding the mower, drinking a beer. Is there any other way to mow your lawn sitting on a rider lawnmower? I mean, if I was walking, I wouldn't be drinking a beer. I know that. But that's what they have. That's why. That's how they sell those. Is they put the cup holder on. You know? OPQRST. So everybody remember what OPQRST is? Onset, provocation, or palliative, right? Quality, radiation, severity, time. Okay, good. So our sample history shows our signs and symptoms are chest pain, trouble breathing, patient's clutching his chest and has labored breathing. Allergies to codeine and amoxicillin. Medications he takes, it's a little baby aspirin, nitro, Lasix, Toprol, and glucophage. What's glucophage? Right. Toprol is cardizem. We carry it in the box, still Tizem. Past medical history, of course, because we just saw what was his medications. He's got diabetes, he's got hypertension, he's had 3 MIs with stenting. Again, the last one was 3 months ago, had 3 stents put in. Super healthy, absolutely. He smells like a brewer. Last oral intake, he ate lunch about 3 hours ago. He got his yeast, he got his wheat, his rye or barley. So he was cutting firewood. Sorry, he wasn't riding the mower. He was cutting firewood for about an hour and developed the pain and came in to rest. Thought it would go away. Didn't go away. So his onsets while cutting firewood. Rest improves the pain. Exertion worsens it. Quality sharp stabbing in the middle of the chest on the left side feels like my last heart attack. Oops. Guess what? Radiates to the left shoulder and jaw. 9 out of 10 pain. Oof, 15 minutes ago and hasn't stopped. So what do we do? Rapid transport. The diesel bolus. Heartbeat, blood pressure 164/96, pulse is 104, respiratory 22 and labored. O2 non-rebreather, the system with nitro. The 6 rights of medication administration, including his own. You have to make sure you have the right patient because I love spouses. Yeah. Bob gave it to him. You know, Bob gave him the free nitro. Well, it just so happens he's on sildenafil. What's sildenafil? Big V, the V. The V. So be aware. Be aware of Maud or Bob or anybody slip them their nitro. Oh, he's having chest pain, so I gave him one of my nitro. Well, he's on sildenafil. But so make sure you got the right patient, the right dose, the right medication, the right time, and make sure you document it properly that you assisted. How do we assist someone? Anybody ever told you how you assist someone to take their medicine?
Yeah, so if there's people who will tell them exactly what to do, and they have to take it mechanically, put it under their tongue, wait till it dissolves, don't swallow it, and if they're not able to do that, then we technically gives them, because at that point they're not conscious or anything like that.
Right. If they cannot physically put it in their mouth, we actually cannot give it. That's not assisting a patient for their own medicine. Now, being paramedics, we administer nitro. Advanced EMTs administer nitro in this state. What's the protocol with it? AMTs administering nitro. Any A's?
No.
Okay. What do you have to have? Ooh, the spray, Panata. You have to have the IV in place. Is it still 100?
It's 100 for ACS, it's 100.
Good deal. So IV has to be in place. Why? Advanced EMTs are not interpreting 12 lead EKGs by scope of practice. So even though we may look at that 12 lead that we've acquired and it says acute MI detected or acute MI suspected, whatever it ends up saying, we're not interpreting that. So what's the danger with administering nitro? Hypotension. There's a specific one though that is inferior wall MI specifically, but the right side involvement. So the right-sided MIs will drop their blood pressure catastrophically when you give them nitro. So the theory is that have the IV in place so you can give them fluids in case. However, we're only still sketchy. So the surefire solution is to do a right side and look at that. Make sure they don't have right side involvement. Because the body is dependent on preload so much in those patients, which meaning the blood coming back to the heart, okay, needs to be in sufficient volume. If we dilate the right side of the heart, suddenly we're not going to be developing any preload to fill the heart up, which is more decisions. But again, you guys all said it, load and go, diesel bolus, get them to the appropriate facility, which at this point would be Huggins in town. I wouldn't bypass Huggins in town, that's for sure. So ongoing, shows you how dated these are. Moderated vitals include pain scale every 5 minutes, transported to your interceptor to the hospital. How many times can you assist them with nitro? 3 times. What do you need before he takes nitro? Yep, we talked about that, the IV and the blood pressure over 100. What if he doesn't tolerate the non-rebreather? Sure, hang it down under his chin. Why not? They do have high flow nasal cannulas now. And let me tell you, it looks just like my Great Dane with his head out the window going down the road. The nose is going and flaring like crazy. They're 10 to 15 liters per minute through these nasal cannulas, high flow nasal cannulas. Normally, a nasal cannula is 1 to 6 liters per minute. Well, they should be. They certainly should be. We're not using them in the field. The respiratory is setting them up for long-term therapy to kind of maintain a little bit of airway pressure. Yeah, but it's, yeah, definitely. A lot of it, they're coming into more fashion now. But let it get it below the chin, let it low on them. So what position do we transport them in? Comfort. Position of comfort. Usually it's sitting up. I mean, take all the pressure off their heart. Code 2 or code 3? Go quick. What if he passes out? I love it. This is great. This is working. Exactly. Check a pulse, please. They're not just going to pass out for no reason. Check a pulse, check a blood pressure, reevaluate everything. And if he stops breathing, breathe for him. If he loses his pulse, CPR, put him on the AED. So oxygen therapy, who gets it? Less than 94. How are we going to give it? High flow, whichever is needed, however dosing we need. Who doesn't get the O2? Above 96. Anybody can get O2. O2 is very, you know.
They have poisoning, which is a contraindicator of oxygen.
Wow, that's a new one. What is it?
Paraquat.
Paraquat.
They put on fields back in the day.
Oh, oh, it's like a fertilizer? Oh. Do they use it over here? That's probably why we've never heard of it.
My EMT question. That's it.
Yeah.
Who came up with that? You know, they pay instructors across the country, across the world to come up with questions. I'd like to, that's paraquat. I gotta look that one up. That's great. Oxygen is a drug. So one of the things, I do IFT paramedic in a facility, critical care, stuff like that. Nursing does not consider oxygen a drug. They can give oxygen for anybody without orders, nothing like that. They don't even have to have standing orders for it. They just give it. We actually have to have orders to give oxygen. It's not direct orders. It's in the general guidelines of our protocols, give as needed. But when we do IFT, if they're supposed to be on oxygen and continuing therapy from a facility, we actually have to have it on our orders to continue. It doesn't fall under protocols at all. So I try to get the nurses to understand that. We just can't sit there and arbitrarily hand them oxygen, unless unless it's not related to why they're being transferred. If they suddenly bottom out with their oxygen, we're going to give oxygen under standard orders. But
What about for like anxiety and stuff like that? Sometimes it calms people down. So
Can't hurt. Can't hurt. That's something that's on a standing order. So that's general guidelines. Definitely, it's kind of ironic though. But remember, oxygen is a drug. We have to chart it. So working for private service, if we don't chart it, wasn't given. They do bill for oxygen. Certain insurance companies, Medicare only gives you a straight rate, but private insurance bill, they get a bill for oxygen. So that's why our private service would be on top of their employees to make sure you charge your oxygen there. So nitro, as EMT basics, we can assist to take their nitro tablets or sprays. Sprays are going the way of the dinosaur. They have proven that the nitro sprays do not give a consistent dose from squirt to squirt. So when I used to give the nitro spray, I used to sit there and go shh, to make sure that the sprayer was actually spraying before I shot it at my patient's nostrils, because I never ended up in the right spot, or I shot myself in the eye. Better make sure you have that nozzle pointing in the right direction. But they've proven that they don't consistently deliver the 0.4 milligrams per spray, because again, like any sprayer, they break down and they weren't consistently delivering. The dosage is 0.4 milligrams per tablet of spray. Make sure you follow the 6 rights. Make sure the medication isn't expired. Nitroglycerin is light sensitive and it's air sensitive. So if the bottle has been opened for more than 3 months, it's kaput. If it's sealed, it's in that brown bottle, so it's pretty protected. But it is air reactive and a light reactive. Place the tablet under the tongue. Remind the patient not to chew or swallow it, because they do tend to roll it and swallow it. It's kind of like my dogs. They'll roll it around, try to spit it out. Human beings will do the same thing. Or they'll swallow it. We generally swallow it. Under the tongue, because underneath the tongue is much more vascular than any other area of the mouth, and have them hold on to it there until it completely dissolves. They must have a systolic BP over 100 prior to administration. If it's given every 3 to 5 minutes up to 3 times, provided the systolic BP is BP is over 100 systolic and they are not pain-free. Nitro is a vasodilator. It works by opening the vessels of the heart, allowing more oxygen to get the ischemic areas that are causing the pain. Most likely, they will get a headache if that nitro is valid. If they take nitro of their own, they may actually become used to the headache part, depending on how often they get angina, things like that. Like any other drug, there is a certain amount of tolerance to it, which is why they tell them up to 3 before you call the ambulance. So you'll get there and they'll have taken 3. Well, I took my 3 nitro and then I called. That's why they take the 3 nitro, because usually what the instructions are is take up to 3, then call, not call at the first dose. A nitro headache is a unique experience. Literally, I took the patient the other day that was on IV nitro and IV Dilaudid for the headache, because he was in excruciating pain with the headache after the IV nitro was started. So the Dilaudid took care of it. There was no prior usage of that, but it worked. Aspirin is a rapid-acting antiplatelet. It's an antiplatelet aggregate, they call it. And this prevents the platelets from sticking together, prevents that lattice work from happening with platelets and from sealing up. So, you know, the low dose is 81 milligrams. Our dosage for chest pain is 324. 81 times 4 is 324. Contraindications have already taken a full dose of aspirin, meaning, God forbid, 911 said, yep, go to the cabinet, get an adult aspirin and chew it. Ooh. Anybody ever tasted an adult aspirin? Ooh, God, that's awful. But they do it. You know, it's better than, you know, it's better to have them chew the adult aspirin than not have any aspirin at all. So it's good protocol. But if they've had one of those 324 adults, hopefully you've been found, they've told you about it. Aspirin indications or contraindications, what do you think? Hypersensitivity to aspirin. How about the person who gets an upset stomach?
No.
Doesn't count. Most people get an upset stomach on most medications orally because if they have an empty stomach, all these things are kind of caustic. Even antibiotics are caustic on an empty stomach. So that's kind of relative. You know, what's going to kill them? The upset stomach or the heart attack? So we go with the, let's treat the heart attack instead of the upset tummy. We can give them Zofran, things like that for the upset stomach. And they can get stuff in the hospital IV-wise to take care of the upset stomach. Bleeding disorders, that's another relative one. You know, we want them to bleed. So, you know, there's really no true short of anaphylaxis. So anaphylaxis is the one that we really watch out for. So the first question you want to ask them, what happens with your allergy to aspirin? This is a life or death. So we're going to choose, do you want an upset stomach, you know, or do we want to meet our mate? And this is the one thing we do to evaluate that whole allergy thing. Anaphylaxis is kind of the one that we talk about. Obtain the 12 lead. Whee! So wipe their chest down. If the diaphoretic, they really do need to be dry. Although electrodes are getting better and better, they still can't work in a wet environment. So wipe their chest down. Bare their chest if you can. And this is not a whack against any particular population. If you have a lot of people on scene, you may want to, with the ladies, you may want to scatter some people, send some guys away. I need to expose your chest. We're going to do this as quick as we can. Try not to reach down. I do this, I have to catch myself every single time. I'll unbutton a lady's shirt right up. Well, mine won't come undone, but I'll unbutton it down to here and I'll reach under and place the electrodes all around. It really leads to electrodes bending, things like that, and you get awful traces that way. It really is difficult when you come down to it to do a 12 lead. So if you can, please bare the chest as much as you can. And again, back everybody off. When I worked down in the Boston area, a lot of the times what would happen is the area fire departments would show up and surround a patient with a wall of rubber. And a bunch of guys staring at a mid-40s lady who's having chest pain. She's gonna get really, really sensitive on you and go, yeah, you can't do that, you can't do that, you can't do that. She may bare her chest for one of you, but not for all of you. So you place the four limb leads first, which the limb leads are the 4 traditional, put them on the cardiac monitor leads. Those are the ones that are traditionally, they call them limb leads because they go on the limbs. Ideally, they go on the most distal portion of the limbs, wrists and down at the ankles, not on any bony portions of it. In EMS, we don't generally put them on the arms at all. And I'll tell you why. Immediately, as soon as they move their arms or we go to pick them up or we transfer them, immediately what happens is the electrodes pop off. And that loses our tracing or loses our monitoring. So generally, we'll put them up here, either up on the deltoids, way up high, because even if you move your deltoids like this, they're not going very far. Or we'll put them on the anterior chest right up here, fleshy portion, not on the bone. Electricity doesn't transmit through bone very well, so you'll get bad tracings every single time if you put them on the collarbones. I see a lot of guys coming along, even with adult men, doing this. Putting them on either side of the sternum. Nope, not a good view. So we're taking these chest leads, these V leads, and we're going around like this, only looking at short distances if they're put in wrong positions. And there's something they call axes, just like your 360-degree circle. These axes, you know, it's depending on the view of those electrodes. It's going to change the look of the EKG. So the right one gets the white electrode, the left one gets the black electrode on the chest. The red goes on the left foot, ankle, or left leg, and the right one is the green down there, leg. Looking on the 12-lead chest placement, long as Bob can see this, if you look at this, V1 and V2 are down at the fourth intercostal space, which is the space between the ribs. So you count down, starting with the collarbone way up here high in the center. Just count down your spaces. 1, 2, 3, 4 on either side of the sternum. You put V1 here and V2 on the left side of the sternum. Perfect spot. And then if you count across, we don't put V3 immediately on.
Still seeing and hearing everything.
Okay, very good. So we don't put V3 down immediately. We look for V4. Okay, V4 is the electrode is at the mid-clavicular line at the fifth intercostal space. So we know we're at the fourth with V2. Just count ourselves down another space right here and slide your finger over. Mid-clavicular, which is right here. Ooh, hello. So right here, right under, generally speaking, as you age, flesh droops, no matter whether you're male or female. So right around, right underneath the nipple is a good eyeball guideline for where V4 goes. Right between V2 and V4, halfway between, that's V3. So what's there on our tender gender? Ladies, a breast. Do you put it on the boob?
You put it right next to the crease.
Exactly, right at that juncture. You know, you can put it a little bit towards the sternum, but mostly at that kind of the bend in the crease. Right there is too much fatty tissue. I'm glad she's saying she's right with me. So again, there's usually something right here though, besides the boob. Okay, besides the breast. There's a bra right here generally. Okay, so this is where we have to be diplomatic and understanding. This has to go under the bra. We can't go this way under the bra. We have to go under the bra physically and put the electrode there. Okay, so being diplomatic. If we show up on scene, and I know what happens with my job is if we've got 5 firefighters showing up, I usually say, gentlemen, if you wouldn't mind, turn around. Or do it in your ambulance. I generally like to do it in the house because the roads around here are atrocious in New Hampshire. So that's where V4 goes. V3 goes in between V2 and V4. V5 is at the same level as V4. So mid-clavicular line, which is right across right here. Mid-clavicular, clavicles, mid-clavicular on both sides. Okay, mid-axillary line is right here. Axillary line, sorry, is right here. Mid-axillary line is in between mid-clavicular and axillary. So draw a line, fourth intercostal space. Point goes V5. And then V6 is on the axillary line.
So they
Same level.
You can quickly find 1/6 and you put place 5.
You can do that, absolutely, absolutely. If you're good, you know, you can do it pretty quick. I mean, pretty much they're in the same line, so you can boink boink right at the same time. So Here we are. So what is that doing for us? If you're looking at this chest right here, that is providing a camera view in a straight line. So look at the heart as the focus point. We're looking from these V electrodes to go through the heart. So it's looking toward, most of them, V6, V5, V4, V3 are all shooting towards the right shoulder. V1 is shooting across. V2 is usually shooting towards the left foot. And it gives you different views camera-wise, just turning right around in a circle. They're grouped together into two pairs as to what they're looking at. V1 and V2, these right here, the heart is basically sitting just like right underneath those. They're looking at your septum. The septum, the bifurcation of the left side and the right side of the heart. The V3 and V4 are looking at your anterior portion of your heart, okay? And V5 and V6 are looking at the lateral portion of the heart, lateral meaning towards the left side. And if you remember the letter SAL as the way they're laid out, V1 through V6, each of them pairs. So S, V1, V2, A, V3, V4, L is V5, V6. Make sense? Okay, so putting a caveat to that, what we're also looking at is our 4 leads are also looking at different views too. View 1, V2, through 1, 2, 3, AVR, AVL, and AVF. And all of those are different views of the heart as well. And those are also grouped together. So all of these are providing camera bird's eye views of the electrical conduction system of the heart. And because we know that the electrical signal doesn't pass through a injured muscle or an ischemic muscle, it changes the view of the EKG from normal. Now note right here, this is showing a right side EKG, which we would suspect in an inferior wall MI. So which are leads 2, lead 3, and lead AVF. If we see elevation in that, we're going to go to a right side, which is leaving V1 in place and moving over V2 and V4. Most of the time we just use V4, V4R, they call it. We just take the V4 lead, which is right here. We just move it to the same position right over here. And it just shoots the signal across and looks at the right side of the heart. Does that make sense? Just a nice camera view, just pan it right around the heart. This is why 12 leads is so good at what they do. Guys have any questions? All right. That's it for the ACS portion of it. I'm going to talk a little bit about stroke. What does our time look like? This will actually be a lot quicker than the previous one. As long as I can get it to work. Okay. So a heart attack, what we talked a little bit about earlier, just to define a heart attack a little more, an MI, it's a blockage of one of the coronary arteries. A blockage either temporary, could be a vasospasm, could be a complete plaque blockage, anything that prevents oxygenation of the coronary muscle. Stroke is almost the same kind of similarities. It's a brain attack. I took a course in neurology with a EMS group in Boston and Mass General. It was specifically, and they used that brain attack. That was the whole presentation, and it was two hours long, and it was really interesting. They had a lot of when they do the same thing they do with a cath, they thread the needle in and go up and highlight the cardiac muscle and look at the coronary arteries and everything. They were doing the same thing on a fluoroscope with the brain. And in a lot of places now they're going in and pulling clots out of the brain and restoring circulation of the brain. And it's kind of the same thing that they do with cardiac caths and percutaneous angioplasties and stuff like that. They're doing with the brain now. And it's pretty good. Portsmouth was starting the ability to do that at one point. I'm not sure if they're still, they went forward with it. Excellent. I haven't been paying attention because I've not been medically in that area for a couple of years now. But it's kind of this whole lecture, it's actually a good pairing between the two topics for training is ACS and stroke because they're very similar. The electrical transmission between neurons and the electrical transmission between cardiac muscle fibers are almost the same. Close proximity, they jump from one to the other. So it's a really good lead in. So with stroke, just like ACS, stroke is a broad paintbrush kind of term. Stroke and hemiplegia simply means one-sided paralysis. You know, it's the third leading cause of death in the US. Number one is ACS, number two is cancer, lung cancer, I believe, and number three is stroke. So 70,000 strokes a year, 160,000 deaths still. You know, and it doesn't really vary. It's amazing. We have all this medication technology to control things like blood pressure, but ultimately there are other causes of stroke that is not involving blood pressure. And some of the things that we do lead to stroke. You know, we don't even know it. So modifiable factors are, you know, TIAs. TIA is a transient ischemic attack. It's a mini stroke that's kind of a warning stroke. Okay, you got something coming. Let's fix the problem. And that's where they try to get those treated early so they don't end up with being major strokes. Diabetes, getting your diabetes under control. Hypertension, medications. AFib, new onset AFib is a big cause of stroke. People that are in AFib, they don't even realize it because of the quivering of the atria. It causes thrombi, embolus, things like that in dead areas of the heart where it forms clots and they get released and they travel to the brain. Substance abuse and smoking. Smoking's gone way down. Vaping is kind of taken its place, but non-modifiable risk factors include age, gender, race, and family history. If your mother and father had strokes, you've got a high level chance of having a stroke. That's unmodifiable risk factor. As you get older, your risk factors go up because your vessels get older. There is no, with both ACS and with stroke, age is not a restriction. You know, you can have a 10-year-old have a heart attack. You can have a 7-year-old have a stroke. I had a 9-year-old in Rye Elementary School that had a stroke when I was on the fire department. And the nurse did not recognize it, denied it, tried to send him back to class, said he was faking until the teachers said, hell with this, picked up the phone and called me directly at the fire station and said, you need to come down here. I have a student that is not acting right. He's acting like she was like, it looks like he's had a stroke. Like, what we write down, and sure as hell, he had a stroke. And so, needless to say that that nurse wasn't employed very much longer, but, you know, I think it was like 10, 20 years later, she got let go when she retired. You know, but, you know, I don't, because we carry a lot of assumptions with us, you know, a 9-year-old can't have a stroke, and no, you know, you're 20 years old, you can't have a heart attack. Again, presumption when we're young in our careers and things like that, you know, it's being proven wrong. We've been proven wrong hundreds of times. and it continues. And we try to correct the wrong. Your youngest was 8? It's shocking, isn't it? Yeah. Ooh, hate that stuff. Ugh. So of those who survive an initial stroke, the initial onset, the symptoms, the most frequent presenting problem is one-sided paralysis, unilateral paralysis. So during the acute period, there's a high incidence of associated neurological deficits, which is why we do these neurological exams on strokes. We try to find out what the deficits are initially and see how it progresses. Now, one important medical concern is the incidence of other things that may affect management and rehabilitation of strokes. So early on, way back when I was a young pup, strokes were a BLS call. Medics very rarely went on strokes, and when they did, it was just BLS measures to the hospital, and they sat on them, and they watched. They sat in a room at the hospital. They watched them evolve. They didn't really get aggressive with them. Nowadays, they're getting super aggressive with strokes because they realize that they can reverse an awful lot of this neurological symptoms, that they were years ago they were sitting on. And they were just, back then they were just concerned with the rehab. It wasn't about, fixing the problem. President Eisenhower had several strokes while he was president. Bed rest, that's all he got was bed rest. That's it. No control of blood pressure, no aggressive therapy as to trying to relieve the stroke, no identification of what kind of stroke it was, nothing, just bed rest. If you recover, you recover. If you don't, you don't. Nowadays, it's get them to the hospital quick, identify what kind of stroke it is. And then we transfer them to, either we treat them on scene if it's a thrombotic stroke, treat them with strepto or alteplase or TPA, to try to break up the clot, or we do the whole fancy intervention like Portsmouth is doing and go up there and pull it out, and embolectomy. That's aggressive stroke. Restore the circulation, just like they do with coronary artery blockages. They go in there with the angioplasty and they widen the vessels up. This time they're going and removing the clots. So all of it's geared towards time frame. What's the symptoms? Identifying them early, and initiating the appropriate level of care. Last known well. So different types of strokes that we have out there is not necessarily important for us to identify. But again, our stuff is still pretty at the basic level, but understanding the types that are out there and why we're intervening. So the number one, the ischemic style of strokes, these are the silent ischemia. There's no symptoms. It's caused by plaque buildup. And like a coronary artery spasms, these are the ones that are the TIAs. They're coming in as TIAs. And they're, sometimes they're symptom free and they resolve very quickly because they're just spasms. They're like migraines, just sudden spasms that close off an already partially blocked cerebral vessel. The cerebral thrombosis, which is the most common stroke, that is the person who's been inactive for quite a long time, sitting in bed. Maybe they're recovering from a skiing accident. They broke their leg, they did a femur fracture where they're immobilized, or they did pelvic fractures and they're immobilized, and so they're not moving around a lot. So they're developing clots from just stagnant blood, and they're suddenly now they're up and moving, they broke free of the clot. And boom, it goes up and it travels around the body, and it goes to the area that's the most narrowest vessel, which is a capillary. If it gets through and gets up to the brain, that's where it blocks off that vessel and occludes it. It's a thrombosis. So these are the ones that it's blocking the vessel itself with a big blob of platelets and thrombi. So it blocks the flow. Sometimes there's TIAs beforehand, but sometimes the symptoms will come and then they'll go. And everything relaxes, but the clot kind of is still there. and then it moves. Now, it was stationary and there was a little bit of blood getting by, but now it broke free now again. It just went further where the vessels are even more small, and now it's stuck. It's now it's become a real stroke, and now it's a incidence where we now need to intervene. They're now showing symptoms without any clear up in 24 hours. Then there's the cerebral embolus. The cerebral embolus can be anything. An embolus is an object. A thrombus is a blockage. So an embolus, so divers, how many divers are actually on the department?
6.
When we rapidly rise holding our breath, besides the fact that we can blow up our lungs, what are we concerned with? An air embolus, right? Let's take that air, we're going to throw it into the circulation. It's a big blob of air going around the circulation, and that's going to go to the pumpkin and potentially cause a blob. And so that air embolus, when it gets to a blockage point, that becomes a thrombus. It's an air thrombus, but it's still a thrombus. So these are all less frequent than normal. You know, the plaque breaks away. It's the amniotic fluid embolus. So pregnant ladies can end up with a amniotic fluid emboli with flying. You know, there can be bone fragments. There can be bone marrow fragments, things like that. They can all become emboli. Less a strong occurrence, but something we do as EMS providers, specifically an advanced provider or a paramedic can do, or a nurse. We can shear off the end of our IV catheter, and it can become an embolus and can cause a stroke. So that's one of the reasons why we never, if we are advancing our catheter, we never reattach the catheter to the needle while it's still in the vein, because we could cause catheter shear. But anything that travels through the bloodstream and just ends up creating a blockage. So different types of strokes. One's a hemorrhagic stroke. These are, generally speaking, these are the ones they used to presume that everybody had. Everybody was hemorrhagic. You can't really treat it. You know, it's a lot less common because a lot of the times this is coming in as aneurysms. So they become pain, they get headaches frequently. And a lot of times now they're CTing these headaches early on, and they're seeing the vessels with a bulge. That's the bulging tire syndrome. You've seen the little, the thought of a bulging tire, a weak area of a tire, when you fill it up, a little bubble on the outside of it, usually on the sidewall. That's kind of the aneurysm system there, and that's a weakness in the wall of a vessel. And that's the one now that they're identifying earlier. So we're not seeing a lot of these, but these hemorrhagic strokes are more deadly because they're bleeding. They're active bleeding into the brain. So they blow out the vessel and it's just bleeding all over the brain tissue. And the brain does not like blood anywhere except inside the vessels. None of the body likes blood anywhere except inside the vessels. If you remember from the the ACS lecture, we talked about, you know, the only contact that the rest of the body has with blood is inside the vessels. Blood doesn't go anywhere else. It just is inside the vessels. It's designed to get down to that capillary level where it marches in a line and allows diffusion for nutrients and everything else to pass into the vessels onto the blood. So when there's blood in a hemorrhagic stroke suddenly goes all over the inside of the skull, it irritates the hell out of the brain. And it causes damage, and it damages a lot. Traumatic brain injury is basically the same kind of concept, bleeding into the brain, and it causes a lot of damage. So it increases intracranial pressure very quickly, and people herniate from it if the bleeding continues. But it also, you know, hemorrhagic stroke causes ischemia itself. It causes, because of its losing the blood that would be delivering nutrients to the brain. So the pressure from the blood compresses the brain and affects the function. So a hemorrhagic stroke really just starts with pain. You know, they call them subarachnoid bleeds, you know, in the arachnoid layer, or the, you know, subdural bleeds, things like that. Those are hemorrhagic strokes, subarachnoid, subdural, any intracranial bleeds. I haven't personally, but I actually don't get headaches except sinus headaches because of the diving. But when somebody tells me I have a headache, I have to believe them. And if they say it's the worst headache I've ever experienced in my life, okay, I believe you. I just don't know because I only get sinus headaches. But that is the exact language that they'll use. It is the worst headache I have ever experienced in my life. And they'll tell you exactly where it is too. Exactly. Right here. Right here. Not, it's never right here. There's no brain right here. That's all sinuses. I know that. I know that headache. That originates in my sinuses because it's straight in from the forehead. But, oh, I get a headache right back here. I've got a headache over here. They're really specific to where it is, but it is the most excruciating headache they've ever had.
Is
Can
it
you-
an ongoing long-term headache or is it?
Sudden onset. Yeah, sudden onset usually. Just came out of nowhere.
It just stays.
Yep, stays and doesn't go away, nothing they do. So the subarachnoid, the blood vessel of the surface of the brain, so it starts pushing. So the subarachnoid bleed is right here and it starts pushing. And that's why they can point out where it is. And not people that have migraines. So people will tell you, yeah, I have migraines, I have them frequently, you know, but they've had history of having these headaches. So it's not sudden onset, that's recurring. It goes away. This headache does not go away. No, even if they give them Dilaudid, this headache's not going away. So the pain and stuff like that is definitely never going away. The affective arteries burst. The aneurysm, which are pouches in the artery, a lot of this is congenital. My friend Mike had a cerebral aneurysm when he was 32. He had a clip. He went to Mass General because, again, he was having headaches, but he was in an area where it was actually causing spots on his vision. So he went and saw a doctor and said, yeah, let's get a CT. Hey, look, you've got a aneurysm right in the back of your head. So he went into Mass General. They went, put one clip on either side of it. That was that. And Mike was a hockey player. He's had to take 3 years off of playing hockey, but he went right back to playing hockey right after that 3-year period. If they find it early, they can fix it. They, you know. But that's a congenital portion of it. It was there at birth. They just don't identify him that early. And head injuries can cause it too. You know, these are my friend Donnie Sistito was hit by a baseball bat in the back of the head when he was 18, walking down the street in Manchester. He was jumped by a gang. And besides the fact that his personality completely changed after that, few years later, he ended up with a aneurysm, and they identified that early, and he got it fixed. So I mean, it does happen. But all of these things, if you have long-standing hypertension as a history, it's going to aggravate these areas that are aneurysm prone, that have standing aneurysms. So stroke and hemiplegia. So, you know, generally speaking, the right side of your brain controls the left side of your body. The left side of your brain controls the right side of your body. So, but it's not true about your vision. Okay, the right side of your brain controls the right eye. What you see out of your right eye is the right side of the brain. What you see out of your left side of your eye is your right side of the brain. No, left side. You guys understand what I just said. Left is left and right is right when it comes to vision. But the rest of it is opposites. So if we have a deficit on the right side, we know that the left side of the head is involved, left side of the brain. So analytically, we can concentrate on that. Doesn't mean a lot for us in the short term, but as far as the doctors go, that points them in the right direction, so identification. So a cerebellum stroke, it controls our reflexes and much of our balance and coordination. So some of the tests that we do look at balance and coordination. Our FAST exams, our Cincinnati stroke exams, the Los Angeles exam, all incorporate some sort of balance test. The brainstem stroke is the area of the brain that controls our involuntary functions. This is our life support. Sonia's mother here had a brainstem stroke. She knocked out everything above her brainstem. Sad, but true. When you do that, your automatic functions go away and you're on life support. But it also things like eye movement, hearing, speech, swallowing. So you can have a partial brainstem involvement. So not all the brainstem is knocked out, maybe just a little bit. So you're going to lose some swallowing, they may be not related to the control of their mouth, but it may be just the speech. Swallowing may be a problem. Sudden onset, frequent choking. Frequently, besides the fact that somebody like me who likes to talk all the time, I come from a family that my grandfather used to talk while he was eating all the time. He would shove a big wad of steak in his mouth and chew and talk the entire time at dinner. Besides people like that who would have just by their own actions have a tendency to choke, this is the person who's normally eating, not talking, suddenly has trouble swallowing. They can't completely swallow food at times. They're aspirating, stuff like that. Sends out red signals about they need to be stroke evaluated. Hearing on one, suddenly losing hearing on one side. I can't hear suddenly on there, or I can't see over here. I have a blank spot on this side. Sudden onset, those are indicators of stroke. So any symptomology that's sudden numbness, weakness, face, arm, leg, one side, anything one-sided really sets off flares because we know that one side controls the other side. So it's unilateral, one side or the other, not both. If they suddenly do this, they're suddenly blind. Might not be a stroke, could be. Might not be though. Compare it to other symptoms going on. Do they have it suddenly both sides? If they can't see both sides of their face are drooping, they can't smile at all. They're flubbing words all over. They may have bilateral stroke going on, maybe a universal bleed. Sudden severe headaches. That's that subarachnoid bleed, the worst sudden severe headache of my life. Difficulty seeing in one or both eyes, confusion, trouble speaking or understanding. Sudden, I don't recognize my wife all of a sudden. Who are you again? Sudden, out of the blue. Nothing, nobody with somebody who has, they've got early onset dementia. We've already identified that. Now suddenly they go, oh, I can't recognize my wife. But, 2 hours from now, the person's recognizing their wife. This is something that's now their memory's suddenly gone out the window. Loss of balance or coordination. So stumbling, suddenly unable, sudden alteration of gait. They were walking normally, now suddenly they're not. They're weak in the legs. They can't hold themselves up. So treatment, just like time is heart muscle, time is brain when it comes to the stroke. So identification of when they were last known well is the number one thing we get answered. When was the last time you saw them well, if they're with someone? When was the last time you saw them well? We need to know that because a lot of this comes in a time window. Now the window starts to expand a little bit as time goes by. It used to be 3 hours. I think it's now 5. It's 5. But things like TPA, which breaks up a clot, has to be given within 3 hours because it doesn't do really much good after that. But a lot of these things like going in, the embolectomies and things like that can happen at the 5-hour window. 24. Thank you very much. You're a big help because that stuff's all new to me. But you know, they got to correct the causes of hemorrhages too, like that, you know, and understanding that the sudden onset, the worst headache of their life, asking the wife, hey, has he had any headache or anything like that? Oh yeah, he was complaining earlier today of the worst headache of his life. Then suddenly he's not speaking well. He's talking like my Great Dane. Bum, 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 bum. You know, so our function, as time goes on, you know, function generally doesn't improve. It gets up to a certain point, it'll return, but then it plateaus, and they pretty much won't get better after that. So as time goes by, that brain tissue no longer is going to be responsive to therapies, so it won't recover. So going in and doing the embolectomy, you know, 3 days from now is not going to do them any good. They need to be within that 24-hour period. TPA needs to happen within the 3 hours. So it's very important. Again, I can't stress, you know, when was the onset of symptoms? Some of the residual side effects of strokes. Never heard of emotional lability. I'm not sure I've ever heard of that word, but that mood swings, depression, suddenly moody. So I had a guy in Rye who was an incredibly church-going member of the Catholic Church in town, never swore a day in his life, had a stroke, and suddenly he was a Tourette's patient. Okay, we had sudden bursts of emotion using a lot of expletives that he had never uttered before in his life. And that's how his wife described it. Suddenly he's acting like a Tourette's patient.
Lability, the fact, the quality of being likely to change.
Okay. That's a dictionary one. Depression, sudden onset depression. Well, so my mom died 2 months ago or a month and a half ago. I'm depressed. Yeah, that's not sudden onset. That's an event that caused, you know, a depression. But suddenly they're depressed when they're normally happy-go-lucky kind of person. That's odd. You know, within a couple hours. Perceptual effects, difficulty recognizing the wife, difficulty recognizing the children, the grandchildren, or things like that. That's all sudden onset, you know, changes that really need to be addressed. Difficulty planning, carrying out simple tasks, tying the shoes. That's one that happens frequently, is they suddenly can't tie their shoes. They suddenly can't figure out how to put the key in the lock of the door of the house they've been in for 35 years or 40 years. You know, they suddenly forget where they live. They've lived there for 75 years, but nope, suddenly can't remember where they live. Carrying out simple tasks, you know, bathrooming, toileting. Loss of awareness, one-sided neglect. So we've seen the patient with a stroke that pretty much their arm is hanging down. You know, you're carrying them out, their arm's hanging down. And I don't even notice it. The arm's bent backwards. They don't know it's there. They're not even aware, just completely gone, not recognizing it. Dysphagia, difficulty swallowing. Aphasia, difficulty putting thoughts into words or understanding speech. So putting thoughts into words. So this would be you can't teach an old dog new tricks. So you tell them the phrase, and it doesn't have to be that one. That one tests a couple of different things. The phrase, you can't teach an old dog new tricks, you're having them repeat it word for word. So that's when they're sitting there stumbling over the words, not by function, meaning they can't form the words, they can't remember the words to form them. Or they're looking at you, I can't remember what she is to me. Looking at his wife, I can't remember what she is to me, but I know she's something really close, meaning his wife. I know who she is, but I can't remember what her relationship is to me. You know, you can't put those thoughts into words. You know, understanding what's going on, difficulties. So how do we reduce our risk for stroke? Lifestyle changes. Stop smoking. If you smoke, don't smoke. If you don't smoke now, don't pick it up. Aspirin regimens, if you have been identified as an early risk person, usually a daily aspirin regimen. that comes and goes. I can tell you that even the daily 81 aspirin of people who are in a certain age group that, you know, doctors have said, hey, you know, you're over 40, you might consider adding a daily aspirin to your dose. Remember the Bayer low dose, they specifically are targeting people. The medical knowledge came out probably in the last 2 years that actually has no benefit. That's what basically the JAMA has come out and said, yep, it has absolutely no benefit for someone to randomly take an aspirin. Now, someone who has a heart problem, you know, who's had heart surgery, who's had an MI, who has angina, that they have proved that a daily aspirin is beneficial. But it's the people like, you know, me over 40 who have no history of heart attacks or strokes or risk factors of any kind. Taking a daily aspirin has absolutely no benefit. It doesn't prevent it. Blood thinning medications. So if you are an AFib patient or they are an AFib patient, blood thinners are almost mandatory because they have to prevent the clots from happening. If they're a person who is prone to DVTs, varicose veins, a lot of people with varicose veins are prone to DVTs. DVT is a cause of strokes, deep venous thrombosis in the legs. Not post-pregnancy varicose veins or during pregnancy varicose veins. If they cropped up during pregnancy, you kind of can't rule those in as risk factors because pregnancy causes varicose veins in itself, meaning the person who's never had children, who's a male usually, females too, there are females out there that have never had children, those ones who have varicose veins have been identified as a category of a risk factor. Having carotid endarterectomy. So carotids develop plaque, the plaque in carotid arteries, which are partial blockages, sometimes they're complete blockages, those can break free and cause strokes. Endarterectomy goes in there and basically roto-rooters the carotid arteries to prevent strokes. They usually end up on blood thinners for a while too. Experimental drugs designed to fix cellular damage. So, you know, some things like chemotherapy, some immunotherapies. My mother was on immunotherapy. She was at high risk for stroke while she was on immunotherapy. Regenerating neurons, things that are designed to fix people who have had neurological damages from multiple sclerosis, Lou Gehrig's disease, things like that. They're at high risk for stroke. So reducing the risks there and then get them getting on the proper treatment. MS and Lou Gehrig's disease are a big risk factor for stroke, even in the young. My friend Billy Gorin, who I've been a colleague of his, we were in the Boy Scouts together. He was in EMS with me. He worked for Action Ambulance. He worked for Lifeline Ambulance. He worked for AMR. He has MS. He's on blood thinners now. He's on a neurogenerating stuff. He knows he's a risk factor. He's 50. So, I mean, identifying early. Remember, not everybody is the elderly person having a stroke. Rehabs, you know, people who have strokes and people who have, just like people who have cancer, they become, it's a social stigma. So somebody who has slurred speech, does it mean their brain's not functioning? Remember, our cognitive ability may not be what's presenting. We may be just slurred speech. It may be a speech area that is our stroke is being affected. Doesn't mean they can't hear, you know, doesn't mean they're stupid. Doesn't mean they can't understand what you're saying. They just can't put words together. So my mother, with her oral cancer, she had part of her jaw removed. So you couldn't really understand what she said. It was hard. And what was happening was people thought her brain was affected. It wasn't. It was physical impairment of her jaw that was preventing her from talking. But it was a stigma, and it's socially traumatic. So they get isolated and they start grieving. It's sad because they think that their life is over, and it's very traumatic. So if you can't understand them, they understand you can't understand them. They're trying, and it causes huge emotional problems. besides the fact that there's huge physical factors that they have to deal with. They can all, if I had a stroke right now, I couldn't be a paramedic. You know, I didn't, unless my stroke went in there and got repaired. Can you imagine, you know, somebody who has one-sided deficits trying to start an IV? I'm not ambidextrous. I mean, I'm not that talented. I took a patient last night that was ambidextrous. I asked because I had to have him sign the clipboard, my paperwork. Do you sign with the right hand or the left hand? Both. Wow. You sign your name for checks on with both hands? Oh no, I just use my right. Okay, well, she can write with both hands. That's more talented than I am. Wow, that is immense. You have like hugely developed cranium. Oh, one of them. Catholic? No, she went to a Catholic school. People are just surprised I can actually write neat with my dominant hand, let alone two hands. You know, it's both hands. God. Speech therapy helps. A lot of these people recover, but it's never to the way that they used to, unless they have had that time frame where they could reverse the effects. So again, back to the onset is really important. 20%, it's actually gone down 20% requiring long-term care because we're intervening so much more. It's gone down a little bit, but it's still right around the same area, probably 15% at this point. But it's still, you know, people still require long-term care with strokes of some sort. The recovery is affected by the extent of the brain that's damaged. How long has it been without oxygen, that particular area of the brain? Patient's attitude towards rehab. Maybe they've given up. You know, the grief process is really interesting, is they've accepted it, but have they given up? So it affects everything. And then how much support system they have, how their rehab and the team skill of the rehab team, how well they do. Vocational rehab is estimated that 30% of strokes occur in people under 65. One study found that 49% return to work rate for people 21 to 65 years old. It's not too bad. 51% can't return to work, or can't return to work. Went to see Dr. Winteroff and Summeroff at the same time. Physical factors in aphasia, difficulty talking, play a significant role in complications of vocational planning. Some strategy for aphasia: reduction in the working hours of territory coverage, selective interaction with customers. Again, if the customers can't understand what they're saying, it leads to mutual misunderstanding, difficulties, increases the stress on the patient. Reliance on overlearned behavior, stuff that they've always done that they do well. You know, less on language and stuff like that. Initial help from relatives or closer. Job carving, creating a job for that person, and a lot of additional information that's available out there. Guys have any questions? Stroke's amazing, and neurology is one of the most dynamic fields out there with medicine. It's changing all the time. It really is. This week's in vogue is next week's. Yeah, we've already passed that. Wait, that's yesterday's news. We're moving on to this new one. You know, it's great. Thank you very much for coming. It's good to have you. Thank you for coming, Bob.
Thank you. Worked well.